Well, hello everyone. My name is Michel. Thank you very much for joining us. Today, I'm delighted to host Dr. Raul Martinez Fernandez, who will be talking to us about the role of focused ultrasound in the management of Parkinson's disease. Dr. Raul Martinez is coordinator of the high-intensity focused ultrasound program in HM CINAC in Madrid in Spain, and is a world leader in this area. As always, before we start, I would like to remind everyone that this session is for information and education purposes only. So if you are seeking medical advice, please make sure that you consult a medical professional. Well, Raul is definitely one, but Mark and I are not. There will be time for questions at the end of this presentation. So if you want to ask a question, please use the Q&A function, the tab at the bottom of your screen, to ask that question. And so for those of you who don't know us yet, No Silver Bullet is managed by Mark Lambert and by myself, with the aim of sharing Parkinson's expertise. So we really aim to help you and frankly, to motivate you to make informed choices on how to adapt your lifestyle, to manage your symptoms, and hopefully slow down disease progression. We post the recordings of our webinars on YouTube and Spotify, and we also post short videos on TikTok and Instagram for those of you who know those platforms. Details are available in the chat section at the bottom of your screen. You can find the details of each of those media that I mentioned a second ago, as well as on our website, that is nosilverbullet4pd.com, nosilverbullet4pd.com. But let's come back to today's topic and to Dr. Martinez-Fernandez. Raul, thank you very much again for agreeing to speak to us tonight. The stage is yours.
Well, thank you, Michelle, very much for the introduction. And of course, Mark and you for the invitation to speak. It's an honor for me. I'm going to share the screen, right? It is an honor for me to be here. I'm going to speak over 30-35 minutes. Hopefully, there are going to be a lot of questions, so we'll have a very nice discussion. I've changed a bit the title of my presentation because, well, you probably all the attendants and you know that we have many treatments for Parkinson's disease, but most of them are symptomatic treatments. The unmet need in the field, and this is something all researchers are working very hard to find, is something which can change disease progressions, which can restore that neurodegeneration that has been produced because a person has Parkinson's disease. So could focused ultrasound be one of these therapies? We'll see at the end of this presentation, and we can further discuss in the discussion. Okay, so these are my disclosures, and just a very brief introduction. I'm from Spain. I was born in Barcelona. I got my neurology diploma nearby Barcelona in Girona. Afterwards, I worked as a general neurologist for some time, and I decided to go to London, to the National Hospital of Neurology and Neurosurgery in Queen Square, which is a very well-renowned site worldwide. It's one of the most famous sites in neurology and in movement disorders worldwide. I spent there 6 months. I published my first papers there, and then I went back to my hometown in Barcelona to work as a movement disorders neurologist in clinical practice for a couple of years. I was pursuing an academic career, and therefore I moved again. I went to Grenoble, which is the birthplace of functional neurosurgery, of deep brain stimulation. I did there a 2-year fellowship, clinical and research. And after these 2 years, I was offered a position in Madrid in the then recently inaugurated HM CINAC. CINAC is a neuro research facility. This is our facility for basic research, and it was created and it is devoted with the objective of treat and study Parkinson's disease. Our team consists of neurologists, of electrophysiologists, of biologists, physics, engineers, neuropsychologists, and neurosurgeons, and we have one common goal, which is to stop Parkinson's disease. One of the tools that we are using to do so is focused ultrasound. For those who are not familiar with the therapy, the currently in-market device of focused ultrasound is this one. Essentially, this is an ultrasound transducer, which is compatible with an MRI. And in this transducer, you can find more than 1,000 ultrasound beams. By the confluence, guided by MRI, by the confluence of those 1,000 beams, we can create in deep brain structures, in selected deep brain structures, we can create a thermoablation. We can create a lesion. And I'm going to show you, I'm going to explain afterwards why a lesion is therapeutic. But that's the mechanism of action of ultrasound. This is a novel therapy, or relatively novel already, but this combines two classical concepts. The first is the use of lesions, of ablation, to treat neuropsychiatric disorders. That started back in the 50s of the last century. Thousands of interventions were performed worldwide. And of course, at the time, it was quite invasive, as you can see here, but it was quite efficacious. I mean, the efficacy was good to treat these conditions, PD, tremor, also psychiatric conditions. The problem was at the time the invasivity. There were side effects related to that. And in fact, ultrasound was tested to produce those lesions. You can see here the device. Well, it's more complicated than it is now, as you can see here. And the problem with ultrasound at the time was that ultrasound beams, the energy of ultrasound was absorbed completely by the skull. And therefore, a craniotomy, a window for ultrasound energy was required. In that regard, there was no advantage as compared to classical ablation. And in addition to that, we have no guidance, we have no radiological guidance, and therefore lesions were not very accurate. And at that time, the technology, the approach was abandoned. As you can see here, it seemed like a revolution at the time, although as in that moment, the technology was not still evolved enough to be widespread generally and applied in many patients. In the last few decades, very smart people, this is very interesting, the process of improving the technology, with very smart people developed the modern focused ultrasound. This is like a preliminary transducer with only 500 elements instead of 1,000, but that allowed to penetrate into the brain and to create that thermoablation. Therefore, those limitations which were related to the technology in the last century were overcome, and the currently available, the modern device of ultrasound was developed, and we have it available. One important question is, why so much fuss about FUS? I mean, we're doing a lesion in the brain, but as I mentioned before, we had ways to do it by other means. We can do it with a surgical intervention. We can go into the brain and create that lesion. We also have deep brain stimulation. We had it 10 years ago when ultrasound was developed, and it's a very well proven and therapy, high efficacy, side effects, of course, because it is invasive, but a very good risk to benefit ratio. Well, the reason why ultrasound has spread so much is found, in my opinion, in the Cambridge Dictionary. Surgery is defined by treatment of injuries of disease by cutting open the body and repairing or removing the damaged part. That means that while in these two therapies, deep brain stimulation or lesions provoked or produced by surgical means, we have this scenario, which is scalpels, sterilization. This is in an operating room. With ultrasound, we have this other scenario. The patient is lying awake in the MRI. We are here, no sterilization, and therefore no risk of infection. There is no incision, and therefore no risk of bleeding. And in other words, what it means is that ultrasound has become a less invasive therapy than those previously available. This doesn't mean that the therapy is not invasive, because we are doing a lesion, and a lesion can produce adverse events, but is by far less invasive than the previously therapies that we had. One important point here is, but we are doing a lesion in the brain, and that is good, that is therapeutic, yet, yes, yeah, it is. And why is that? Well, because we know that there's a circuit in the brain, which is called the basal ganglia, and this circuit, in the context of Parkinson's disease, in the context of a depletion of dopamine, is impaired. The activity of this circuit is impaired, and that abnormal activity is related to the symptoms of the disease. That means that there is no dopamine, or there is little lack of dopamine, the activity of this circuit, of this brain circuit, is disturbed, and it causes, and this distortion on this activity is producing the manifestations of the condition. What happens if we lesion one of these structures? If we abolish this abnormal activity, what happens is that the brain goes back to normality somehow. It's not back to normality. Of course, you still have Parkinson's disease, but this abnormal activity related to the symptoms is reversed. And that has been shown. We showed that in this study. After doing a subthalamic lesion, the so-called PD brain-related metabolic pattern reverse. And with the reversal of this pattern, of this activity pattern, the symptoms improve. This has also been shown with essential tremor, a lesion in another nucleus, which is called the thalamus, a thalamotomy, can reverse these activities, tremor activity related to tremor. So this is showing us the mechanism of why a lesion is therapeutic. It is therapeutic because it abolishes an abnormal activity which is causing the symptoms. Well, let's go to the treatment itself. How is the patient journey? It starts in our clinics. We visit a patient, we evaluate. Usually these patients are either essential tremor or Parkinson's disease, because these are the two main indications. Then we evaluate the patient and we say, okay, you might be a candidate, a clinical candidate. I will explain that afterwards. Then after that, we perform a CT scan. This is important because we have to evaluate one characteristic of the skull, which is called skull density ratio. If this ratio, it depends on the density on the skull. And according to that density, the ultrasound energy can penetrate higher or is completely absorbed by the skull. And depending on this ratio, a patient can be suitable for treatment or not. Above 0.4, the patient is suitable. Below 0.3, the patient is not suitable because all the energy is absorbed and there is no energy to produce that thermoablation. If this is good, if this is correct, then we perform a brain MRI, blood test, just to see if there is any coagulation problem or platelet count, etc. Neuropsychological testing, and a visit by the anesthetist just to check that, well, the patient is stable, doesn't have any major problem, and will be able to tolerate the treatment. If everything is okay, then the patient is a good candidate and we perform ultrasound treatment. I'm going to show you a couple of videos of the treatment itself. Here you see a patient with essential tremor. We place the frame, the stereotactic frame on the head of the patient with local anesthesia, and then the patient is placed on the MRI. Here you can see the transducer that I showed you before. You see the patient is awake on the MRI, and there are two stages of the procedure of the treatment. The first is find the target. We know which targets we have to point to. I mean, we know where these targets are located, and we have to direct all the ultrasound beams to that target, because there, on the focusing of all the ultrasound beams, the lesion will be created. Then we direct all the beams there, and we can start to deliver the energy to create the lesion, which is produced progressively. I'm going to show you this video here. You can see let me stop one moment. You're going to see here the hand of the patient that is shaking. As you can see, this patient has Parkinson's disease because he presents resting tremor. And here in the screen, you're going to see like a curve, a green curve, which raises here, which is the increase of temperature. And you're going to see what happens to tremor when energy is delivered and temperature increases. Okay, you see the patient shaken, then we deliver the energy, bam, bam, it goes up, and tremor stops, as you can see here. So when we see this in one treatment, we get into the MRI, we assess the patient, and then we can know whether the target we're pointing to is correct or not. If we have a good clinical effect without side effects, then that means that we are directing properly the ultrasound beams, and we can increase even further the energy to produce the final lesion. If we are not at a good place, if we see some side effects, we can move, and we can move it before creating the final lesion, because we can assess the patient with low energy delivery. And we see the patient with low energy delivery, and if there's any side effect, then we move the target to go into the proper target. So therefore, what I want to say is that the production of that lesion is quite controlled. It's not fully controlled. This is why we can have side effects, but it's quite controlled both by clinical evaluation and also with neuroimaging. Well, I'm not going to go into all the evidence of focused ultrasound, because as you can see here, there are dozens of papers in the last 6-7 years. A lot of groups are treating with ultrasound, a lot of publications, but instead of going through the specific evidence, I'm going to address a few concepts, a few points that I think are important and are relevant. The first is that essential tremor is tremor. Mainly, it's mostly tremor, and it's a quite simple condition. I'm not saying that it is simple, but it's a quite simple condition, because the thing that happens with time, the evolution of the disease is usually increasing of tremor, while Parkinson's disease is much more complex, is much more complicated, is more diffuse, it involves other systems, not only the dopaminergic. And as you can see here, and you're probably aware, there are many symptoms related to other neurotransmitters and to other systems. Therefore, it's a wider condition. It's a more diffuse condition. And for this reason, applying ultrasound for essential tremor, which is what was the first indication and is one of the two main indications, it's like, putting down a single fire with a group of firemen. While treating Parkinson's disease with ultrasound is like trying to put down a highly widespread fire with one firefighter. And, I want to highlight this because we have to be, it's not that ultrasound is not good for Parkinson's disease, but we have to be aware which signs and symptoms are we treating with the condition. We're not treating everything. Deep brain stimulation does not treat everything either, but we have to balance expectations in order to understand properly what the therapy can provide us and which are the better candidates for the therapy. One thing that has allowed ultrasound is treating patients, treating a wide array of patients. As it is less invasive than the brain stimulation, we can consider treating patients like this one, who's a lady with 4 years of disease progression. It's not severe. I mean, she's quite asymmetrical. She does have Parkinsonism on the left side of this is off medication. She has Parkinsonism on the left side of the body, bradykinesia, rigidity. She doesn't have tremor. The right side of the body is pretty well preserved. And in this lady, we started with medication. She was not optimally controlled, and therefore we decided to create, to undergo ultrasound lesioning. You see her 6 months afterwards off medication, bradykinesia has improved, rigidity has improved, her general picture is much better, and medication could be reduced. Probably nobody would treat this patient with deep brain stimulation because she was too mild. But as ultrasound is less invasive, then you can consider treating this kind of milder patients. And this is also supported by evidence. There are a couple of articles in which ultrasound was applied to patients with short-term time of disease progression, less than 4 and 5 years. And it showed, preliminarily, that these patients can be contemplated. And also, we can go to the other edge of the spectrum. We can treat patients who are too old. This patient had a lot of brain atrophy. He would never be candidate for deep brain stimulation because of that atrophy. But with medication, he was not well controlled. You see that he's very severe. The tremor is very severe. So in fact, I was reluctant to treat this patient because he was too fragile. The brain atrophy was quite remarkable. But at the end, he complained. He said that he didn't want to live with that tremor anymore. So we decided to treat him. He didn't have any other option, therapeutic option. And as you can see here, the improvement in tremor on the right hand is pretty good. These patients are treated unilaterally. Okay, so the other side is shaking. In here, he's off medication. but the effect on the right side is pretty good. And in fact, in the clinical trials that have been published of ultrasound for PD, we have treated patients of more than 75-year-old with almost 20 years of disease progression and with a high score in the scale of motor complications. So we have treated patients who are maybe too advanced to be treated with deep brain stimulation because they were too old or too fragile. These patients can also be contemplated with a less invasive therapy. And in between, we have another, patient with moderate disease. I'm showing two examples. These patients are a bit more severe than the first lady, but are definitely milder than the last video that I showed, the last man of the video. But they were still moderately impaired. Medication did not provide proper benefit, and this is why we decided with them to undergo ultrasound ablation, and you see that the results are pretty good in both cases. So this slide is to show that the spectrum, the array of patients that can be treated is wide, and they only have to have one single thing in common, which is that they are markedly asymmetrical. And this is because so far we are doing lesions only unilaterally. We're only treated patients unilaterally. Why is that? Because in the past, where lesions were performed surgically, bilateral lesions were associated to a high rate of side effects. The techniques that were used at the past were very invasive. So would we encounter the same rate of side effects with a less invasive therapy with bilateral lesions? Well, that we don't know yet. We have some evidence. I'm going to show it afterwards. But so far, it is important to acknowledge that the indication is unilateral. And therefore, only those patients who are really asymmetrical could benefit from the therapy, because only one side of the body could be treated. So, which is the clinical indication in general for PD? Of course, afterwards you have to individualize in each patient, but in general, the indication is for asymmetric patients with mild Parkinsonism on the least affected side, which is refractory to medical treatment, which is not properly controlled, and there are no major exclusion criteria. Age or time of disease are not limitations as far as the patient is not too fragile. And those patients who have bilateral impairment with dyskinesia, with fluctuations, axial features, freezing of gait, those patients are better candidates for deep brain stimulation than for ultrasound. So I also want to point this out because it's not that ultrasound is there to replace DBS. It's not that it's not in competition with DBS, but these two techniques are complementary. Some patients will be good candidates for one, and some patients will be better candidates for the other. And this is the advantage of having a new tool, that you can select properly the patients that would suit better the effect of a given therapy. Okay, I have been talking about targets, right? I have been saying, we have targets on the brain. This is a main, I'll try to make it easy, but this is a main discussion in the neurosurgical field. We have several targets on the brain that can be approached in Parkinson's disease. This is a discussion that comes from the deep brain stimulation field. There are many discussions, many papers addressing whether we have to go to a nucleus called the subthalamic nucleus, we have to go to the GPI, which is the nucleus pallidum, which of these is better to stimulate the STN or GPI, and in ultrasound is similar. At the end, that is also an advantage because we have four main targets that can be addressed with ultrasound. One is the thalamus, the subthalamic nucleus, the globus pallidus, and the pallidothalamic tract. And why do we have this difference? Because each target has a different profile of benefit. Each target has a different effect. For instance, the thalamus has a very high effect on tremor. Those patients who are tremor dominant with little rigidity of bradykinesia can be good candidates for a thalamotomy. If they have rigidity of bradykinesia, thalamotomy would probably not improve it sufficiently. On the other hand, subthalamic nucleus is a good target for the three motor signs of PD: rigidity, bradykinesia, and tremor. Patients presenting the three are better candidates for a subthalamotomy. And GPI, the pallidum, is a very extremely good target for motor complications, for dyskinesia or for dystonia. Those patients who present this phenomenon can be treated better on the GPI. Another target is the pallidothalamic tract, which is not a nucleus, it's a tract on the brain located in another region, as you can see here. This evidence is more preliminary than in the other targets, but it seems a promising target to treat both motor signs and complications of the disease. And this slide, what wants to show is that, again, it is not that the STN is a better target than the thalamus or the GPI, it's that each target provides a different effect. And therefore, we have to select patients according to the clinical manifestations of each of the patients. But of course, safety comes first. What about safety? We're doing a lesion, as I mentioned, there can be complication related or side effect related to the treatment. I have to say two main things or three main things. The first is that most of the patients have side effects. It's very frequent to have side effects. However, these are usually mild. That means that the severity is not important. Most side effects are mild, and most of the side effects are also transient, and they resolve within few weeks. Therefore, if you have a good benefit, even if you have, well, side effects at the beginning or immediately after the treatment, in a few months, you're going to keep the benefit while side effects will resolve. Which are the most frequent side effects? That also depends a bit on the target, but these are in general. The most frequent, for instance, is gait instability or speech disorders. Then with the subthalamic nucleus, you can have dyskinesia. With the thalamus, you can have sensory disturbances. And probably the most concerning is motor weakness, because the internal capsule, which is a structure which is like leading the strength of the body, is very close to all these nucleus. And therefore, if you impact there, you can have a motor weakness as a side effect. Again, these are usually mild and transient, but of course, permanent side effects can happen and has happened to all groups worldwide. Well, you're doing a lesion, and once the lesion is done. What happens with the long-term effect? Because the disease progresses, right? The disease with time, symptoms impair. Well, we already have long-term follow-up of patients treated with ultrasound. This is a paper in which patients were treated in the thalamus, thalamotomy for tremor, and up to 5 years, the effect was preserved. We also published our evidence in the subthalamic nucleus, and we saw that after 3 years, as you can see in these bars, the motor MDS-UPDRS score, which is the scale that we use to assess the motor manifestations of the patient, immediately after the treatment, they improve, they decrease, as you can see here, and they kept improved throughout follow-up for up to 3 years. Very importantly, there were no delayed side effects. Those who were present immediately after treatment either resolve or improve, but nothing happened afterwards. It's not that after 1 year you present with a side effect that was not present. And therefore, that in terms of safety profile in the long term, the therapy is pretty good. What about, because as I mentioned, we have been doing unilateral lesions. What about bilateral treatments? The disease is diffuse, as we said at the beginning, and it affects both sides of the body. Well, there are a few trials ongoing. We just finished one of the trials that hopefully will be published soon in the next few weeks or months. And we included only 6 patients in whom we perform bilateral treatment, but in a stage manner. We treat one side of the body, and after some time, we treated the other side of the body. And I'm going to show you the video of one of these patients. This is a lady who had, as you can see here, asymmetrical Parkinson disease of medication. She was quite affected on the right side of the body, not as much on the left side of the body. And then we decided to treat the right side of her body, which is the left hemisphere, because this is crossed. 4 years afterwards, as you can see here, the same lady, the right side of the body has improved remarkably, rigidity, bradykinesia, and tremor, but the left side of the body is impaired. And therefore, we propose her to get into this trial and to be treated on the other side, on the left side of the body. We perform a subthalamotomy, a lesion on the subthalamic nucleus, which is the one that improves all motor signs. And this is the video that she sends us 3 weeks afterwards, the second treatment. She was in a wedding, and she sent me this video on WhatsApp. So she was doing pretty well with the hair. We have to shape the hair, so she has the hair very, very short, but she was doing well. And this is one of the patients who benefit the most from ultrasound in our experience. Okay, so far I have been talking about clinical symptomatic effect, improvement rigidity, bradykinesia, and tremor, but let's open a window to something else, which is not only improve the symptom, but also the evolution of the disease. We published this review, this viewpoint in 2019, and we proposed that ultrasound might eventually be used not only to improve symptoms, but also to improve the evolution in the disease. First way to do is doing a subthalamic lesion, a lesion in the subthalamic nucleus early on disease progression. And why is that? Because the subthalamic nucleus has projections to the substantia nigra. The substantia nigra is the region of the brain where dopamine is produced, and is the region of the brain which is degenerated early in Parkinson's disease. This projection from the subthalamic nucleus to the substantia nigra is excitatory. And with the subthalamic nucleus having abnormal activity, this projection becomes very, very high. And this activity can damage the substantia nigra. Therefore, we have damage of the substantia nigra because of the disease, and the subthalamic nucleus keeps the activity of the nucleus, keeps damaging the substantia nigra, and the disease might be evolving faster. Why if we lesion this first early and we abolish this activity, so we prevent this projection to damage the substantia nigra? And not only that, but why if we can somehow open with ultrasound the blood-brain barrier, which separates the brain from the blood, and that can allow us to introduce drugs into areas which are neurodegenerated in the brain? What if we can do this approach, this dual approach? I'm going to show you this example. This is a patient of 3 years of disease progression. You're going to see here, he's quite asymmetrical, but he's mild. He's not a very affected patient, although he was not feeling well. He required relatively high doses of medication. He was not well controlled, and we decided to include him in this early focus study, a pilot study of treating patients initially or early in their disease. Why? To try to change disease progression, as I mentioned before. The outcome was very good. This is 2 years afterwards, and the patient is practically the same. I mean, it's better than before treatment. But this has been practically stable for 2 years. And it really looks like the disease has, like stagnant. I'm not saying that neurodegeneration has stopped. I don't want to say that. But the clinical picture of the patient is really, really very stable and with low doses of medication. In this study, we included 12 patients. As you can see here, the median time of disease was 3 years, so very early disease, and they were quite young, 52 years. And this is, again, the UPDRS motor scale, the scale that we use to assess the motor manifestations of the disease, and it is reduced immediately after treatment, and this benefit is kept at least for 12 months. Side effects, again, we were very accurate and we tried to be very precise in reporting side effects. Again, they happen because they happen, but they were mostly mild, and all of them practically resolved. Only the patients gain weight. We still don't know why. This happens as well with deep brain stimulation. There are many mechanisms that has been suggested, but the reason itself is not known. But apart from that, side effects were very mild. Now, trying to expand this evidence, we're involved in the early. We have written a protocol, and we try to start one trial called the Early Focus 2. Will address the same population, early population, but with a larger sample. And the other technology, not technology, because this is focused ultrasound, but the other modality in which ultrasound can be applied is not to produce lesions, but as I mentioned, to open the blood-brain barrier. The blood-brain barrier is a barrier that separates the brain from the bloodstream, and it avoids that any drug or toxin can get into the brain and damage the brain. But at the same time, it prevents therapeutic agents, drugs, to get into the brain and have some beneficial effect on the brain. Well, focused ultrasound, if we apply it in low intensity, can open this blood-brain barrier. And it can be open in a spot that we have decided. And of course, in PD, we would select a spot which is related to the neurodegenerative process. There are several equipments to do ultrasound-mediated BBB opening. It was initially tested in the mouse animal model in Alzheimer's disease. It was shown that by opening the blood-brain barrier in this animal model of Alzheimer's disease, some proteins which were causing the disease or were underlying the pathogenesis of the disease were removed. Was like a clearance of those proteins, and afterwards it was applied in humans. These are pilot studies only to test safety, and we used BBB opening in Parkinson's disease patient. You see here this white sign here in the brain. This shows the BBB opening, and after doing this in 5 patients, we tried to do this in one structure of the brain called the striatum. The striatum is where most of the dopamine of the brain goes, from the substantia nigra to the striatum, and is where neurodegeneration in the brain is also very prominent. And therefore, we tested to open the blood-brain barrier in the striatum in order to deliver something there, which we still have not done because it takes time, you know, the whole process. Maybe you're familiar with this article. It came out like 2 or 3 months ago. It was in New England Journal of Medicine, which is the most important journal of medicine in the world. And they did exactly the same thing that we were pretending to do, but in Alzheimer's disease. They opened the blood-brain barrier and they deliver aducanumab, which is a recently developed drug for Alzheimer's disease. They were able to show that aducanumab penetrate better on the brain, and therefore eventually we would expect a higher effect, a higher therapeutic effect of the drug. Well, that was a breakthrough in the field, and hopefully we could be able to do that as well in Parkinson's disease. Again, not only to treat symptoms, but also to improve disease progression. And I'm coming to the end. Another modality in which ultrasound can be applied is neuromodulation. This is not doing a lesion. This is not opening the blood-brain barrier. This is just changing the activity, modulating the activity of the brain in specific areas. This is completely non-invasive. I mean, you have no lesion, you have anything. If you undergo an MRI the day after that you have done neuromodulation, there is no change at all in your tissue. In fact, it was tested initially, of course, in animals, and it was shown in the animals that there was no damage at all in tissue. And afterwards, it was tested in healthy subjects, in healthy humans, and it shows that it modulates somehow some networks in the brain, depending on, again, on the target in which we apply the neuromodulation, but it has some effect on mood and modulate the functionality of the brain. This is the only study in which ultrasound neuromodulation has been applied in humans. It's a study in which a few receive the neuromodulation, others receive like a sham procedure, pretend to receive modulation. And what was shown was that this is a measure of brain activity. The activity of the brain in those who receive neuromodulation was modified. Therefore, we can eventually, if you remember what I said at the beginning of the talk about the abnormal activity related to Parkinson's disease, we could contemplate that maybe if we do this neuromodulation, which is completely non-invasive, this doesn't result in any side effect. If we do it like many times per week, we could be able to modify this activity, and we could be able to improve clinical symptoms, and who knows if disease progression. Maybe in the future, we will be at home, we will place a transducer, and we will spend half an hour, all of us, half an hour receiving some ultrasound energy in order to change something in our brain, but just to improve our condition and our health. Well, thank you very much. This is my team. Up here, my whole team in CINAC, or part of my team in CINAC. And here, our ultrasound team, Dr. Obeso, who's my boss, who's the director of my site, was not here in the photo, but he's always there when we perform a treatment. And of course, the team is the most important thing. It's not one person who does the treatment. We have a neurologist, we have neurosurgeon, Dr. Marta del Alamo, bioengineers and physics, of course, Tamara or nurse, which is critical for the treatment, anesthetist, and MRI technicians. As I told you, the success of this treatment depends also on the selection of your team. Thank you very much.
Raul, thank you very much indeed for a fascinating presentation that really makes you want to jump on a plane to Madrid and talk to you more about it. So that's my enthusiasm. So let's just look at some of the questions. A question that was entered quite early on and that you have partly touched on, but it might be worthwhile to recap, is what are the advantages and disadvantages of focused ultrasound versus DBS?
Well, of course, that's a very relevant point, and I understand, because when we started using ultrasound and presenting it in forums and with colleagues, that was the question always. The main advantage, in my opinion, is that it's less invasive, that you don't need skull incision and you don't need penetration into the brain. That's the main advantage, and therefore you avoid all complications related to surgery. The disadvantage, there are a few, is that so far bilateral treatments are granted with deep brain stimulation, and we still need to explore this further with ultrasound. And of course that, well, when you do a lesion, for the good and for the bad, the effect is permanent. If the lesion is not well placed, then you can have either a partial effect or a side effect. And that can happen. The technique is very precise. It's unusual to have permanent side effects, but that can happen. And with deep brain stimulation, side effects are probably less frequent, although when they happen, they are more severe. So I would say that these are the main, but again, I don't want to, I mean, for me, we are doing both techniques. Both techniques are very good and have the switchable candidates. These are complementary. It's not a, this is not a versus DBS versus ultrasound, but DBS and ultrasound.
Thank you, Raul. Maybe just a further clarification. If DBS does not provide the results that one would want, I guess the electrodes can be removed, although it is very intrusive, while in the case of a lesion through focused ultrasound, if things don't work, you can't do another lesion to fix it, or can you?
You can, I mean, that depends on the reason why things don't work. I mean, if the lesion is too small, that can happen. If the lesion is too small, it's not covering all the area or all the region of the target, then you can remake the treatment. You can place the patient again on the MRI, and you can reshape the lesion. That can be done. We have done it a few times, not a lot, but in a few patients. So you can done. But if you have a side effect, a permanent side effect, that, well, usually, as I told you, they are mild, but that is what it is. It's difficult to recover fully if you have a permanent, I mean, if you have an impact on the internal capsule,
Thank you very much. A question from someone who I have only his surname, so I won't mention it, but actually this person was asking, why is the psychological evaluation important? You mentioned that was part of the things being done prior to going ahead with the operation.
That's a very good question. Thank you very much. This is because the procedure lasts about 2-3 hours. The patient has to collaborate. Patients get anxious because it's not easy to be there awake with transducer placed here while we are doing a lesion in your brain. So we need to be sure that the patient is not going to get confused, is going to collaborate, not too anxious. And if patients are cognitively preserved, it's more easy to control that. We have treated patients with mild cognitive impairment, and it worked well, and cognition did not deteriorate. I mean, there is no cognitive side effect of the therapy. That doesn't happen. It's just to be sure that we can do it surely, I mean, properly, and without additional complications,
So thank you very much for that, Raul. There are a few questions about location. So let's just start with the location of the clinic where you work. It is in Madrid.
Yeah, it is. Well, it's in Móstoles. Móstoles is a city 10 kilometers south of Madrid. But yeah, I mean, we say Madrid because it's everybody knows Madrid and Móstoles. but it's nearby Madrid. I mean, I live in Madrid. I live in Madrid.
And someone was asking, are you doing PTT as done in Switzerland? I don't know what PTT stands for. I'm sorry.
This person knows what he talking about. We have done a few. The last two of them in a context of a clinical trial which is ongoing. We do not do it regularly. We do not think that we don't have enough experience, and the community doesn't have enough evidence to do it regularly. I mean, to like indicate it in a patient who comes asking for ultrasound. We still need more evidence, in our opinion. In Switzerland, they have done it, and they have done a lot. They have a few publications, but there is no yet definitive publication. One is coming in the next few months. One publication will be out, and then at that point we'll see. But we have performed a few in very well selected patients. Yeah.
Thank you. Yeah. Before we move away from DBS, I just had one further question. Is that can you have focused ultrasound after having had DBS?
Yes, but you have to remove the electrodes. And also you have to understand why DBS has not worked well. I mean, if it is because electrodes were not well located, which is the typical, it's the typical reason why DBS is not effective. If the electrodes are well located, DBS is very effective. Then if it is because of that, then you can remove the electrodes and either place the electrodes again or replace them, or do a lesion. But if you have the electrodes located or placed on your brain, it's not possible to do ultrasound.
Understood. But the other way would possibly work. You could have a focused ultrasound and DBS later. That's another question we had.
You can do it. You also have to know why ultrasound has not worked well. But I mean, we have one patient who was treated in our site 7 years ago. He was treated unilaterally. In fact, he was the first patient that we treated with a sulfalamotomy. He was treated unilaterally, very good effect for 7 years. But the other side started to have, to have Parkinsonism. And in the end, he was operated on with DBS in both sides of the body. But I mean, if a well-located lesion does not, and proper lesion does not need the brain stimulation in the future, because it has a permanent effect, a permanent benefit. But you can do it if necessary.
Thank you very much. We basically have a question from Edward asking about the UK, and he believes that focused ultrasound may not be cleared for use in the UK yet, although there is a proposed trial in Scotland. I really am not aware. Can you just?
Well, the team from the National Hospital of Neurology and Neurosurgery in Queen Square came to our site 2 weeks ago to attend, just to meet with us and attend a few treatments, because they started to do it. They're doing it. They have not yet go through, I mean, all the steps in Parkinson's disease, all the targets, etc. They have started with essential tremor, but they are going into that, and they are very, very good team. Very strong team experience. I mean, I think in, I don't know, 12 months time, something like that, probably it's going to be not I don't know if it's standard treatment, but it's going to be available in UK, in London. Yeah.
So pretty soon in the UK. Now 40 to 45% of our audience is based in the US or Canada. Sorry to drag you around the world, but can you tell us a bit more about availability in the US or North America?
Whereas there, I don't know, I think it's the country in the world with more equipments. Boston, Virginia is a very, very good team. Chicago, it's acquiring in brief. New York, Cornwall, Florida. I mean, many sites, and in Canada as well. In Canada, Sunnybrook is a very strong team as well. We have collaborated with them, and we know them well. So both in Canada, I think there are, I don't know if there are other sites, only Toronto, but in the US there are a lot of hospitals offering the therapy.
That's great news. Lisa is asking about post-operation, post-procedure speech changes and whether those can be reversed. I think you answered that already. I think that your answer was that most people have sometimes short-term effect, but in only rare cases do they last longer.
Most are transient, and I'm not concerned of a speech after unilateral treatment, because most of the patients resolve if they have any complication.
So Donna is asking about how long does focused ultrasound work? Now, I remember you showed us some slides with like, I think 5 years or 3 years, 5 years. What is
Yeah.
the longest surviving patient do we have having had focused ultrasound?
If we speak about Parkinson's disease, in our experience, it's 8 years. And for those in whom the effect was good at the beginning, this effect is sustained. This doesn't mean that the disease has progressed. Of course, as I show you in that picture with all the figure of all the symptoms of PD, these patients progress. As they progress, if they receive deep brain stimulation. But the benefit achieved at the beginning, that benefit on tremor and rigidity on one side of the body, that is persistent for at least 8 years.
Thank you very much. Martin in Ireland is, I think, he has PD, doesn't take any meds. He has tremors in one hand only. He's fit, exercises a lot. He was diagnosed 2 years ago. Can he be considered for focused ultrasound? Sorry to be running a question from a potential patient to you, but.
Yeah, he's in fact the typical prototype. He's the prototypical candidate for ultrasound, but I would recommend him to take some medication first, because if you can be controlled well with medication, why undergoing a potentially harming or potentially a treatment which potentially can result in side effects? So he's a good candidate. I mean, for what that he just told us. But I really would recommend him to start with medication, levodopa, low doses, and it will be good for years probably.
Thank you very much. Someone anonymous is raising an interesting question here. You mentioned that people were putting on weight after the operation, and that person is basically suggesting that it could potentially be related to the fact that people who have tremors burn a lot of calories due to their tremor, and they could put on weight because they're not burning those calories anymore. I don't know if that makes sense.
Well, that's a good theory, a good hypothesis. We think, I mean, we have contemplated a lot of them. We think it's not that. We don't think it's that. Our main hypothesis, or main and the hypothesis in the community with DBS is something more like related to behavior. That maybe those patients became a bit impulsive and they eat more, or something changed in their sense of requiring food, something like that. We think that it's more a network thing than a purely physical thing.
Thank you. So another patient with, I think some of those cases are interesting because we had someone being fit and having had PD for 2 years. Now I have someone here anonymously saying that he has had or she has had the disease Parkinson's for 18 years and has been progressing slowly. Has responded well to levodopa, but was originally tremor dominant. Would you consider such a person for focused ultrasound?
Yeah, why not? I mean, if she's, in good shape, she's not too fragile, his manifestations are asymmetrical. Yeah, of course. There's no limitation of age. If she has 18 years disease with motor complications, bilateral, etc., then not at that case. But if not, yeah, why not?
Thank you. I have 2 questions actually from people asking about levodopa. So if you take a lot of levodopa and you have the focused ultrasound, can it be turned down afterwards? Or someone else asking not so much about taking a lot of it, but do you take less of it, however you were taking before?
Usually, it's similar to DBS. With a unilateral treatment, usually you can reduce levodopa to 25%. You can reduce at 25%. 25, 30%. Those patients, the lady I showed you with bilateral treatment, she was under 800 milligrams before treatment, and now she's taking 50 milligrams of levodopa. But that is not general. Levodopa is always necessary because, as you know well, while ultrasound and deep brain stimulation, they treat motor features, there are other non-motor manifestations and other manifestations which require treatment, medical treatment. So I would not recommend to withdraw completely drugs after a successful treatment, either DBS or ultrasound.
Thank you. Jack is asking an interesting question, saying that DBS has some degree of adjustment to tailor it to a specific patient after the operation. Does focused ultrasound have any degree of tailoring after the operation?
No, that is one advantage of DBS, of course. No, as I mentioned before, you can reshape the lesion with a second intervention. You need to get into the MRI again. But like with DBS, if the electrode of DBS is well located, you don't need a lot of modifications in the parameters throughout time, over time. If a lesion is well located, this has a good effect, and you don't need to reshape anything, So, but no, that is true. I mean, we don't have this. Ultrasound doesn't have this capacity of modulating. That is true.
Understood. Peter is asking whether focused ultrasound can help non-motor symptoms.
That's a very nice question. We're studying that. I have a grant to study the effects of ultrasound in non-motor symptoms. In general, if I talk about clinical practice, what I would say is that it doesn't have any direct effect on non-motor symptoms, but the fact that the disease is better controlled and you can reduce medication and you can adapt somehow medical treatment, that helps to non-motor symptoms. But the direct effect of ultrasound is over on motor symptoms. Okay, but those improve indirectly because the disease is in general better controlled.
You might argue that you would be feeling less depressed if your symptoms are going better from a motor standpoint.
Exactly.
Or you would sleep better as well.
Yeah.
So David is asking, referring to the slide where you were showing the skull density ratio, he's asking what percentage or proportion of potential patients are excluded?
7 or 8% in Western countries. In Asia, it's about 20%. But in a Caucasian population, is very low. It's 1 out of 15 or 20 patients. It's very rare that we exclude a patient for the SDR.
Thank you. So Peter is raising a point you touched on already, but basically saying that focused ultrasound is permanent and non-reversible versus DBS. You agree with that?
Yeah, I agree, but again, it's not a competition. I mean, it's just tools to treat different diseases, but it's a different tools to treat PD, and both are useful in different ways, So yeah, I agree with that.
But I think that that's also the reason why we're doing those sessions, is to equip our audience with information about various solutions which they may or may not qualify for anyway, and that they may or may not want to do anyway. But at least information allows the patient to choose in which direction to.
Yeah, and so sometimes, I mean, it happens to me many times that a patient comes to my clinics asking for the treatment, and I reject because it's not a proper candidate. I mean, and I send this patient, we perform DBS in that patient. So yeah, the point here is having options. That is the point.
Exactly. So Ralph is touching on something you already talked about. He basically said that he has both essential tremor and Parkinson's disease.
Yeah.
And he's asking if focused ultrasound is aimed at different areas for one and for the other. And I think that you were saying yes, but if you have both, what do you do?
Yeah, that is a very smart question. And I would target, in this case, I would target the thalamus because it has effect for both essential tremor and PD. In case that essential tremor is disabling. If it's very mild, I would target probably the subthalamic nucleus to treat all motor fields. But let's imagine that both tremors are disabling. I would target the thalamus, and I would try to enlarge the lesion ventrally, because we know that in that area, ventral to the thalamus, there is some effect on rigidity and bradykinesia as well. So I would do like not a dual lesion, but a ventral thalamotomy. I would do probably.
Thank you very much. Just a comment to our audience. I see some people are putting questions in the chat, which I'm unable to jump from one to the other. If you have questions, please put them in the Q&A. I think that Mark has probably asked you to do that already, but if you put your questions in the chat, they will not be answered, I'm afraid. But if you put them in the Q&A, that's a good behavior. They will be answered. So Anne suffers from dystonia, and she's asking us whether focused ultrasound can help with unilateral dystonia.
Absolutely. That I mean, that's the one very good. I mean, if we're talking about PD dystonia, yes, and if we're talking about primary dystonia and unrelated to PD, same. You can treat it, and in fact, if it's unilateral, this is a very good indication. It's a very good treatment for that. There is little evidence on the literature, but theoretically, conceptually, it's a very good treatment. Yeah.
Thank you very much. Yes, so a question from Jackie, touching on the topic of triple B, blood-brain barrier.
Yeah.
When you open the BBB, how do you prevent toxins from also entering the brain?
That's a great question. We cannot. So this is why the first studies were done as a safety pilot one studies with the small samples. Consider that the BBB is open for 24 hours. It's transiently open. And that period of time is difficult to, that any toxin can get into the brain. But conceptually, it could happen. It could happen, of course. So far, and there are studies showing like producing BBB open, repeated BBB opens over a few weeks. So far, there has been no safety issues in that regard. So we think, I remember one of the patients whom we opened the BBB, it was in 2020, and he was diagnosed the day after, he was diagnosed with COVID infection. And we were, oh my God, this is going to penetrate into the brain, but no, it didn't happen. So, but this is a good question. If drugs get in, why not toxins? Yeah.
But I guess you cannot open the BBB barrier on a weekly basis or something. It's something which you can do as a one-off from time to time. So for people who need continuous introduction of the drug into their brain,
exactly.
They probably would struggle to have it all the time.
Yeah.
Good. So a question from Isaac, who I think is based in Spain, judging by his surname, but I don't want to be judgmental here. But he's asking whether it's better to have the procedure earlier than later on time. And he's also asking, and that's why I think he's based in Spain, if it's done under Seguridad Social or Privado.
Yeah, it's both Seguridad Social and Privado. We're a private center, but it's also provided by the Seguridad Social, which is true that we and another team in Barcelona are the most experienced because we started in 2015, but it's provided also by the public health system. The question related to the moment to treat PD is a very good one. We cannot say that it is better to do it early. We cannot say that because we don't have the evidence. What we believe is that it is better in some cases. Those cases, imagine, I'm going to put an example. Imagine that you have 3 years of disease, you have asymmetrical unilateral tremor and bradykinesia, which is not severe but moderate. We are taking levodopa and you increase doses to 500 or 600, and you're not improving enough. What do we have to do? Increase levodopa, double or triple, trying to treat this while the other side is well preserved, waiting 3 years until, okay, it's 6 years of disease progression, then we can consider a second-line treatment. No, that patient requires something at that moment. So we consider that in that case, treating the patient early would provide benefit at that moment and probably in the evolution, because we would not over-treat with medication that patient. So the proper moment depends on individual patients. And also, this is well known that any therapy which is given early has a better effect. Ultrasound, DBS, drugs has a better effect. So therefore, at that moment, we would expect a better therapy. But other early patients would not be candidates for the treatment.
Thank you, Raul. Someone is asking if it's expensive like DBS. No, I mean, the only thing I can do perhaps is to ask you how much would it cost for someone from anywhere in the world to come as a private patient to your clinic?
You know, to be honest, I don't know because I'm not on that. I'm only on the clinical and research part. I know that in the US is around $25,000. In our case, what I know is that it has changed. In the private hospitals in Spain, I think it is around $10,000 or $14,000, something like that. But to be honest, I don't know for sure.
No problem.
But it's cheaper than DBS. It's cheaper. That I know. It's as a therapy, is cheaper than DBS.
So someone anonymously asking if you plan on doing the PTT FUS, the focused ultrasound procedure. Can you just tell us a bit more about what is the PTT? Because I think that some of the audience knows about it. You know about it. I don't.
Sorry, I know I have used some technical concepts. PTT is the pallidothalamic tract. That is not a nucleus. It's a tract that goes from the pallidum to the thalamus. And it like sort of transmits the activity. It's not that the activity is there, but it's sort of transmission of the activity. Then if you cut this cable, this tract, is somehow like stopping the activity as well. And we know which is the the place where the tract goes through. When you cut the pallidothalamic tract, you have an effect which is very similar to a pallidotomy, to a lesion of the pallidum, because that tract comes from the thalamus and transmits the activity of the thalamus. So that is the pallidothalamic tract.
Thank you very much. Joy is asking us an interesting question, actually, that I don't think many of us have thought about, is what is your structured follow-up for patients having had the ultrasound treatment? Because there are many complaints, she tells us, about follow-up or lack of follow-up in DBS. So when someone has had the operation, do they leave the clinic forever on their own, or do you stay in touch and follow up in a structured fashion?
In our case, in our site, we treat the patient remains in the hospital one night. In some centers, it is ultrasound is applied as an outpatient clinic, and patients leave the hospital the same day, but we prefer to keep the patient one night in the hospital. The day after the patient leaves, and we usually make a visit, a video call, or neurology nurse makes a video call 2 weeks afterwards, and we have a presential visit at 1 month, then 3, 6 months, and 1 year. That's the standard follow-up of an ultrasound patient. Of course, in between, if there are any complications, whatever happens, we visit the patient or we talk with the patient. But this is like the standard. After that, of course, the Parkinson's disease requires follow-up. So you need to follow these patients up for chronically, you know. But this is the standard for in the first year.
Thank you. So someone here has had PTT performed on his right side, but he's telling us that now his left side is acting up and under the form of slowness. So his left side is slower than before. And he's basically asking whether you've come across that kind of situation and what would be your recommendation.
Sorry, I'm reading.
So this is the very last one on the list.
Okay. First, try to control it by increasing medication. So try to treat it medically. Second, if it is not possible, I would need to see the patient. But second, I would consider either treating with ultrasound or placing one electrode. And that would depend on many variants. But the first thing to do is try to control by increasing medication.
Good, thank you. And Raul, it's a bit unfair for me to ask you to answer specific patient-specific questions with very limited information, but I just thought it was interesting to see someone who has had PTT. This
is why I'm here.
So Krista is asking the first question tonight about the low-intensity focused ultrasound.
Yeah.
And she's asking when was the first one done, and is it available worldwide?
The first LIFU in Alzheimer's disease was done in Sunnybrook in Toronto. The first LIFU in PD was done in our site, in humans, was done in our site in Madrid. And well, there are not many. I mean, this is not, DBB opening is not available in clinical practice. It's all experimental. We don't apply it for patients in a clinical basis. Is to first we have to show this evidence that we have been looking for. So I mean, might it be available in the future? Well, we'll see, depending on the results. Probably yes, yes. But it's not as available of ablation, of ultrasound ablation.
Thank you very much. Now a question on the triple B, the blood-brain barrier opening. Yeah. And Jackie is asking whether the microbiome is considered in that process when deciding on eligibility. And she's referring to a potential risk of leaky gut being a risk factor in opening the blood-brain barrier.
No, it's not considered, and it's not known whether it can be a problem. My opinion is that it's not. I mean, it's not a risk factor. I have to say, with regards to microbiome, I mean, I don't want to understate the importance of microbiome, but I think the importance in the last few years has been overstated. Of course, it has a role. I would not deny it, but it's not that, you know, everything is related to the microbiome. In the case, in the specific question, I don't see it as a risk factor, I have to say.
Thank you very much. I think we have done a good job at the questions. I'm looking at the remaining questions. To be frank, I think that those questions have been, in many cases, answered or otherwise extremely specific. Maybe one for Ralph is asking whether the focused ultrasound is available in Paris. No, I guess it's available in Grenoble.
No, in Grenoble it's not. In Paris, yeah, in Paris it's available. Yeah, in Paris, in Salpêtrière, they have
yes. Perfect. And Rodro is asking, how do we make an appointment? I guess probably someone needs to visit your website.
Yeah, I mean, you have my email, so
Yes.
I mean, if they want to write to you, and you can, well, you can feel free to give my email, or I will give you. No, I will send to you the email of our like
Your secretariat or something.
person to arrange clinics. Okay, to arrange.
But that leads me to a question, which is basically probably interesting most people who are not based in Spain. Are you welcoming foreign patients? Is that something you do frequently?
Sure, and we treat. I mean, I see in my clinics, in my movement disorders clinics, a lot of foreign patients, and we treat foreign patients, of course.
So they have to come back on a regular basis for the follow-up afterwards, I guess, to make sure everything is fine.
Yeah. Or we now, we can make video calls from the distance. So, but we prefer to have a presential visit at least after the treatment. We don't like if patients leave and we don't see them again. I don't like that personally.
So Isaac is saying, thank you very much, Dr. Raul, for an excellent presentation. Gracias.
Gracias, Isaac.
He's Spanish, so I was right, but he lives in Scotland.
Oh,
I could not have guessed that one.
Nice place, Scotland. Enjoy.
Raul, I think I will stop the questions there. We have answered close to 40 questions, which is like what we tend to do every time we have a session, which is a good number. There is a few we haven't answered that I'm sorry to people who didn't have their questions answered. They can always send us an email afterwards. I think that importantly, you have helped us, Raul, to really open up our mind to a new therapy that not all of us were familiar with, and it has been a great learning experience. So thank you so much.
Thanks to you. It's been a pleasure, and I have enjoyed very much, and very good questions indeed. I mean, I got
a good audience. I told you.
Very good, very well educated audience.
So I just wanted to tell to our audience that our next session will be taking place on the 11th of March. And we will be hosting Professor Christine Klein from the University of Lubbock, who you probably know, Raul.
Sure.
She will be talking to us about the importance of genetics in the search for Parkinson's therapies.
She's great.
Excellent. I think so too. So we're looking forward to that. Thank you again for tonight and for dedicating your career to helping us.
Thanks
Thank you, Raul. Thank you to our audience. Goodbye, everyone.
Bye-bye.